Good evening, councillors, officers and members of the public. Welcome to this evening's meeting of the Health Scrutiny Committee. Please be aware that this meeting is being recorded and live streamed on the Council's YouTube channel, and I welcome viewers joining us online. Can I request that mobile phones are either set to silent or switched off for the duration of the meeting? Please, could I also take this time to remind members regarding the procedure for tonight's agenda. Should members of the Scrutiny Committee wish to amend, remove or add additional recommendations or requests as part of the Scrutiny Committee's remit, then please could I ask members to state and propose their recommendation at the appropriate time during the debate, and a seconder then to confirm the recommendation. Members will then vote on the additional or amended recommendation as necessary. Members, I kindly ask all members to be mindful of this when preparing questions and comments to ensure that each item receives appropriate attention to scrutiny within the available time. Should the meeting run past the constituted meeting guillotine, members will be asked to extend the meeting in order to finish the business on the agenda. We will now move to apologies received for absence. It looks like we have a full house. Yep, so I'll move on from that. On to item 2 on the agenda. Anybody have any declarations to make? No? On to item number 3 then. Are members happy for me to sign the minutes of the previous meeting? Would anybody like to propose? Councillor Harrison and a seconder. Councillor McLean? Thank you. Yep.
I work for the Red Cross based out of Kettering General Hospital, but like a lot of people that are in that, it covers so many different areas. There's nothing specific on the agenda tonight to do with Kettering General Hospital.
Gotcha. Thank you, Councillor Pengelly. Without further ado then, let's move on to item number 4. We have Jane Bethea, Director of Public Health, to introduce the report.
Thank you, Chair. Hopefully you can hear me. Slightly awkward positioning of the laptop. So this is my second DPH annual report, and lots of you will have heard this at full council and would have seen the video that accompanies this. We're not showing the video this evening. Technology A is quite complex, but also I am aware that people have seen the video already. The purpose of the video is for accessibility purposes, so that people who may be not that comfortable in reading a long report can watch the either truncated or full-length video. So the Director of Public
Jane,
Health...
could I just ask you to pause for 1 second while we sort out the camera issue?
Oh, it's my feet.
There we go.
Thank you, Councillor Pengelly.
There we go. Please continue.
Thank you. Oh, I was mid-flow. Okay, so the Director of Public Health report is a statutory requirement. So I'm required to do this as part of the Health and Social Care Act, and it's an independent report. So it's a report that I do with the officers in the team to say this is the state of the nation, if you like, in terms of the health and well-being in North Northamptonshire, and then we pick a topic that we focus on in that particular report. So as a fairly new council, we're quite early on in our journey in terms of health and wellbeing strategies, which is also a requirement of us as a statutory duty. So last year's report focused on we were developing the health and wellbeing strategy. This one is we are now implementing it, and we're focused on 2 particular areas of the health and wellbeing strategy, that being smoking and also keeping active. Now, I want to say something about smoking particularly because it's really important that we understand that when we think about health inequalities, half of the health inequalities that we see in this country, and it will be no different locally, that we see between our most deprived communities and our most affluent communities, it's due to smoking. Now, smoking still kills 1 in 2 people who smoke. It is something that is incredibly entrenched in some people's families, and some people have grown up with smoking. It's a difficult thing to crack, but there is support out there to do it. So smoking is, from a public health perspective, hugely high profile. It also is what I call a systemic problem in that for our bodies, it affects all of us. So people think about smoking and they think about lung cancer. It actually drives so many different sorts of diseases. Of course, lung cancer, yes, but respiratory diseases like chronic obstructive pulmonary disease or COPD, those sorts of diseases are if we got rid of all smoking, we would get rid of 80 to 90% of COPD. That's how close that relationship is between that horrible disease and smoking. So I make no apologies at all for the focus on that within this report. We have lots to do, but we've made quite a lot of progress. And what I won't do is go through the report in lots of detail, because I'll take it as read, and I know we've talked about this already. But there's still lots to do. And what we want to really focus on as a team going forward is A, narrowing the gap. So making sure where we've got inequalities, we're really focused on that. So we know, for example, that there are communities in North Northamptonshire with really high smoking rates. So we still know that in one particular area of Kingswood, for example, in Corby, that could be as high as 29-30%. And we know that in areas like Oundle, it's about 9%. That has come down in Corby. So the situation we used to have in Corby was that we were the highest level of smoking in England, and that was 2019. By 2020, we'd come down as the third. We were the third, and by 2021, that had come down to 6. So that level is going down, but it's not going down quick enough, particularly when we know the impacts of it. And I've brought Pippa with me today because Pippa's been doing a lot of insight work with our local communities in Corby to try and understand what's really driving that. But one thing I would say is that for some communities, smoking isn't actually seen as a huge problem. People aren't talking about smoking. They're not talking about health issues in their area and tying it to smoking, and that's something that we do really need to address as a council and also as a public health team. So I'll take the report as read, and I'm very happy for questions and discussion, and I will bring in Pippa throughout that so that we've got normally there'll be more of us colleagues. Public health is bigger than myself and Pippa, but hopefully we'll be able to cover the breadth of the questions and areas of discussion that you want to raise. Thank you.
Thank you, Jane. We've developed a questioning strategy with a few key lines of inquiry. So what we'll do is we'll go through those first, and then if any members have anything outside of that, outside of those key lines of inquiry, we'll go to them at the end.
Can I ask a question on the questioning strategy?
Of course.
Just I think that Scrutiny is a really, really important committee, and I think that people should come here and be able to ask open questions and be transparent or whatever. What it says is deemed good practice, best practice told pre-meetings of the committee to plan and prepare for public meetings. Where does best practice come from? Who is saying that it's best practice? Is that us saying it, or is it government? I've looked at Scrutiny reports, and I can't find where it says that is the best practice. I'm just wondering, I know other councils do it, I know the old county council do it, but I'm just a little bit strange that we're having pre-meetings without the press and the public knowing what's going on, and we could be saying, well, we won't ask that because it could put the ruling party in trouble. I'm not saying that happens, but that could happen in the future. So I'm just wondering, where does that best practice come from, please? Who's saying
that's a fair question. Perhaps I can hand over to Raj to answer that one.
Yeah, so that best practice comes from organisations such as the Centre for Governance and Scrutiny. It's just a suggestion to have members briefed before meetings so that they're more targeted and we stick to a structure. As I say, the questioning strategy is just there as a kind of broad skeleton to kind of shape debate. Members are more than welcome to ask supplementary questions as they normally would do. We definitely don't discuss what we won't question at the pre-meetings. It's just a case of what are some of the key themes we're interested in, what do we want to explore and really hone in on in debate. So like I say, it's just there as a structure, kind of a basic idea to get debate rolling, and then members are more than welcome to ask whatever questions they might have.
Thank you, and noted.
Councillor Harrison.
I just wanted to say that obviously this committee is a cross-party committee and we all are invited to go to the pre-meeting. So, you know, I think if there's any transparency required, you could always tell the press what we talk about in that pre-meeting if you needed to.
Yeah, just to reiterate what Raj said, you know, we're not limited to these questions. It's just a general structure so that we know what we're going into. And I think everybody who attended the questioning strategy will know that they've been apolitical. Gotcha. All right. Okay, let's get on to the first key line of inquiry then. Councillor Geary, if you want to start us off.
Thank you, Chair. Before I go into my questions, there's a point you made at the beginning which is quite critical, which was you're kind of saying there's a 50-50 chance if you smoke, there's fatality. there must be other behaviours that have a risk rate as well. What might be interesting is a comparison of things, for example, like drugs and so on and so forth, because clearly you're aiming at the drug that's having the biggest impact, alcohol as well, and that would put it in perspective. That point there brought it home to me so clearly, the flick of a coin, if I'm a smoker.
Yeah, please go ahead.
Oh, it's back. It's back. Absolutely, Councillor Geary, that is a really important point. And there is nothing else that is as harmful as smoking in terms of a lifestyle behaviour. Alcohol, I can do the same for alcohol as well. So alcohol is an interesting one. Again, with alcohol, what people think about when they think of alcohol is they think people that they recognise as someone with alcohol dependency, and they think of liver disease, and they think things like that. Actually, for a woman who drinks more than about 20 units a week, that massively increases their risk of breast cancer. So there is a lot of things that again, is a systemic issue, alcohol. But if we think about some people will drink at a lowest risk level. So there's no safe level for alcohol. That's not true. But the lowest risk level is 14 units and under. So lots of people will drink at that level, and they're unlikely to get very obvious direct health issues from that. But it's not the same with smoking. With smoking, you really don't know. And even if you give up smoking when you're really quite young. So I hear quite a lot that people will say, I start smoking when I'm young, but I'm going to stop by the time I'm 30. Because I think that if I stop by the time I'm 30, when I'm older, I won't get the ill effects of it. And that is true in that your risk of ill health decreases if you stop smoking at 30, but try and stop smoking when you're 30. It's not an easy thing to do. It's an incredibly difficult thing to do, and it has a very similar profile to trying to give up something like heroin. Interestingly, with drugs, you've got me onto one of my subjects of real interest here. So if you look at people like heroin, for example, so people who are entrenched heroin users, who've been using it for a long time, yes, they are at risk of dying from that. That may be from an overdose, but it may be from poor injecting practice, and they can get sepsis. But actually, huge numbers of those people die from smoking-related diseases. Because people who use heroin often are also smokers. Smoking is something that it's a fundamental thing that if we could really reduce that, if we could really tackle that, we would see huge differences in terms of our burden on people's lives and on their pocket as well, because it's not cheap either, but also on the health service and on adult social care and everything, because it's so fundamental. But I'm very happy to I can bring lots of different ways of thinking about things like that. So the risk of taking different drugs, for example, and the risk of all sorts of different lifestyle things. But smoking is absolutely at the core of what we need to tackle here in North Northamptonshire.
Yeah, thanks very much for that. And another point, going through the report, which I found was very, very useful, is not so much about smoking, but when you're talking about activity, one of the things you mentioned was that for an investment of £1, in that particular case, it's going to generate £4 for society. Now, I haven't seen it in any other reports, maybe I've missed it or not, but in terms of, and assuming that information is credible as well, it's quite a useful way of kind of thinking, if we're going to spend money, where's it worthwhile spending? So that's something I'd encourage you to use throughout reports, because it's a very good way of, as possible, making a judgment as to what works and what doesn't. So thank you very much for that.
To respond to that, to say that the return on investment figures, quite often they are nationally calculated. Is it my feet again? Probably are nationally calculated, but we also do some of our local ones as well. So we've looked at return on investment on things like investing in kinds of forms of social prescribing. So when you think about that's a really interesting one, because we might invest a certain amount for every pound we invest in that. Actually, the benefit of that will be felt by so many organisations: policing, adult social care, health, wider council services. So yes, absolutely, I will take that on board. Thank you.
Okay, that would be very useful indeed. Thank you very much. We talk about health inequalities in general, and there's a number of different ways that you can classify inequalities, and a number of different groups which suffer inequality. What are the groups that you concentrate on the most, and why?
So just so we're on the same page about what health inequalities are, I think that's important. So a health inequality, when you get difference in outcomes, in health outcomes, for reasons that are modifiable or unfair. So, for example, we see some of our worst health outcomes in areas where people are more materially deprived, so the poorer areas, for example. So we know that. And there's a very good evidence base around which inequalities happen where and what you need to focus on. So what we do, firstly, the most important thing is we use our data to understand that. So we have a lot of data. We're very data rich as an organisation. We also have our partners who provide data, particularly the NHS. So what we're able to look at is outcomes according to a whole range of different factors. So the things we tend to look at are deprivation. So for example, that's why we know so much about smoking rates in Corby, because we've looked in detail at that. But we also know there's issues around things like disability. So the disability being a protected characteristic, we know that there can be variations in outcomes for people who identify as disabled. We also know that's the same for ethnicity. So we know that, for example, from an ethnicity perspective, on a public health topic such as uptake of vaccines or uptake of screening, that can be different. So there's a number of things. It can be by age, it can be by gender. So we look at all of those characteristics when we try and look at equity, and we try and look at where are those inequalities and what might we want to do differently. And what we try and do is target resources according to that. There's an interesting concept in public health called proportionate universalism, which is where everybody gets an offer, but we might need to really zone in and focus on some particular areas where we know the problem is more acute. And so we use our data to do that. But certainly, I mean, unless people wants to add one from what I've talked about, but deprivation, for example, is a key one, but also would be gender, ethnicity, age, disability, etc.
Because I think that's quite interesting in terms of you have that information. How are you using that in terms of how you direct your services to particular groups? How does that happen?
Yes.
The stats can change potentially.
Oh, and we want them to. Yes, completely. And it's a really good point. So we are a very data-driven service. So we have a team of analysts that will be involved in all of the work that we do. So some of our work is nationally driven because there's some very clear things that we need to do from a national perspective. I'm thinking about, for example, services for children, 0 to 19 services. But within that, what we've got to do is get that right for our local communities. So the way that we do that is we look at a whole range of different data. So that will include data on deprivation. It will also include data on what services are available in those communities. It's really important that we have the right services in the right place. But we'll also use that data to look at how communities are, what they're made up of. So what sort of people, who lives in those communities, and then we look at how we target that. One of the things that we're doing at the moment is looking at hyper-local type offers as well. So you'll know that the way, for example, the NHS is moving is the NHS wants to, in my view, return to a model of neighbourhoods, which, because I'm old enough to remember, that's kind of where it started. So we want to really make sure that we've got the right things at neighbourhood level. So through the local area partnerships, for example, there is a scheme that runs through there where they are developing their own priorities, because some areas might need something very particular. And that the voice of that community might say, we want to focus on drugs and alcohol, for example. So what we will do there is we will get that insight from that local community to make sure we're getting the right offer, but at the same time balance that with data. So, for example, if the local area partnerships in Corby don't talk about smoking, we have to step in and say, actually, but smoking is a huge issue here, and we want to make sure that we're doing that. So it's data-driven, but it's also evidence-based driven as well. So the evidence base for public health is quite strong in some areas. So we'll say what we know we're going to get our best outcome is, for example, investing in a certain intervention in a certain community. But at the same time, we need innovation, so we have to balance that. So through the local area partnerships and through some health inequalities funding that came from the NHS, those local areas are now building up bids to say, let's test and learn something a bit different. So one of the things, for example, in Wellingborough that they're working on at the moment is a movement and dance class to try and engage some parts of that community who are not physically active in a way that perhaps they could or should be. And that is funded through that programme, but essentially it's also got public health input to look at the impact of that and making sure it's evaluated. Because what we never want to do is have a test and learn of something that could be great and then we don't roll it out, or a test and learn of something that's not effective and we don't then use that money for something else, because every pound spent is an opportunity cost.
Okay, so you're talking about hyperlocal. I can think of two examples which might be quite interesting. let's take an area that's regarded as being relatively prosperous. However, within that area, you will have segments that are less prosperous, or for whatever reason, maybe legacy of industry. There are particular health issues. You talk about hyperlocal. How hyper and local are we able to get at this stage, and what are the challenges?
One of the challenges is data, without a doubt. So one of the things that's happened with the demise, if you like, of the sovereign councils is the way the data is reported. National data has changed fundamentally. So we used to get data for particular areas. Now it's for North Northants as a whole. So that is a bit of a challenge. However, what we do in response to that is we work with our partners, our analysts in the NHS, to make sure that we can almost replicate the sort of data that we used to be able to have. When we talk about high hyperlocal is hyperlocal, does that make sense? Yeah. To be completely honest, lots of the issues that people raise are issues in lots of different areas.
Sure.
So, for example, if we look at alcohol is something that lots of different local area partnerships have raised as an issue. Now, actual fact, with alcohol, we know that there is a huge hidden problem, and actually for some of the communities where it's hidden, they are in the more prosperous communities. The other thing that we have to bear in mind is we're rural. We have a very big rural area. And we're doing a health needs assessment, a rural health needs assessment at the moment, looking at that, because an area may be affluent, it may look affluent, but you're absolutely right. I used to do a lot of work around rural communities, and where I used to work, you'd have one farm that was doing very well, and the next farm that wasn't. That's how particularly localised that issue was. But what I'd find across a lot of those areas were issues of isolation, were issues of untreated and undisclosed mental health as well. But also, sometimes the services that were available in other parts of the county I used to work in were not always available in that rural area. And that's something we all need to take on and look at where those inequalities and inequities lie. So we've got a health needs assessment that's being completed in October. It's nearly done, which will allow us to say, so for our rural communities, what are the challenges, and also what does service delivery look like, and what might we need to do differently.
And last question about social determinants, things like employment, housing, transport, certainly in your rural areas, for example. What kind of impact can they have on outcomes in health?
The way I'd answer that is to say that the first thing to bear in mind is that when we look at someone's chance of living to 75, so a death below 75 is classed as premature mortality. And what really drives whether you get there or not, only 20% of that is to health services that are available to you and you access. The vast majority of it is lifestyles. So I can't help but mention smoking again. You may have noticed there's a theme to this discussion. So lifestyles will be what your diet is, how active you are, whether you smoke, drinking, etc., etc. But then also will be the quality of your housing, the quality of your employment, and what access you have to be part of your community. They're all really key things. So from a housing perspective, you get very specific issues like damp and mould. So we know that we've got a new law that's coming in this country fairly soon, which has come from a hugely tragic incident of mould and damp in houses. And it's really important that we recognise the health implications of living in a damp house, for example. And all organisations providing housing will be subject to that law that's coming in, and that's really important. But when it comes to things like education, I mean, education's a huge one, because we know very well that what's very protective for all of our health is having a job that we feel gives us the money that we need to live, but also gives us that sense of identity and gives us that sense of meaning, doing something meaningful. So they are absolutely critical. And what I see in North Northamptonshire is some of the big areas of work we're working around feel quite relevant to that. So from my perspective as a public health professional, the Big 50 gives us lots of exciting opportunities there. That is all about our communities being good places to live. We've got good housing, we've got good employment opportunities, but also we are a major employer. We're a major employer in this area. It's up to us as an employer to provide really good support for our staff as well. So another thing that we're doing as a local authority, and public health are very involved, is something called an anchor institution network. So as employers, we're saying, what can we do to make the lives of our employees better, but also how can we reach into communities so that children leaving care are offered apprenticeships, for example. That's the sort of wider determinant stuff we need to do it as a system to really change people's life sort of projection, really, and where they're going to go. Because ultimately, where you live, who you live around, what job you've got or haven't got, what education you've been to or what you haven't actually accessed or been able to access, and the lifestyle behaviours you adopt are the things that really will influence whether you get to that 75th birthday.
Thank you. Thank you, Chair.
Thank you, Councillor Geary. Excellent questions, and thank you to Jane as well for answering them fantastically. I'll open up the floor now to any other questions within the theme of health inequalities and local population needs. Councillor Harrison, go ahead.
Thank you so much. Thank you, Jane, and could I thank you for your very passionate explanation of smoking and why it is so important. And if I might make a suggestion, you might want to clip that from YouTube and use it, because I thought it was really good. And I think you could use it in all sorts of different forums. And I just wanted to just ask a few more questions around smoking and inequalities. So one of the things that's mentioned in the strategy is around children and young people and vaping. And so I'm quite interested to know, how, again, in terms of data, is there an inequalities slant to that, or is it just a trend and children, young people across the board, whether they're young, younger, older, richer, poorer, that this is a thing that we're just having to deal with, because that would be quite interesting. And are the numbers increasing? Are they decreasing? That would be very interesting, because obviously the worry is that it's not ideal anyway, but that they might go on to smoke in the future. And then another issue, you did mention the health inequalities funding, and I think that comes from the ICB, doesn't it? And I saw again in the report that, one of the things we've done in the arena of smoking was take on more staff, more people out there, helping people to quit smoking. With these changes that are going on at the ICB at the moment, is any of that under threat? And if so, how are we going to manage that?
Two big questions. Hopefully, what I might do is bring, because Pippa is our expert on smoking and vaping, but just to make a point about vaping, and I'm going to use another soundbite now, which is I'm very clear on this issue of vaping. If you don't smoke, don't vape. If you do smoke, vaping might be a way to help you stop smoking. And then you can then reduce your vaping and be completely free of that addiction. But if you don't smoke, don't vape. In terms of inequalities in that picture, one thing we do is we do a shoe survey, so a school survey on a regular basis. And we do see a significant number of, and one of the things that struck me from a recent one, and Pippa will correct me if I'm wrong, was particularly girls. You looked at year 9, for example, there was a significant number there, which is very young to be doing that. And I totally get your point that for some young people, they could go on to smoking. They may have gone on to smoking anyway, who knows, but we don't want that. But there are, I feel, a significant number of people who would never have smoked who are vaping. And we're very clear in the strategy that we don't want that either. The issues with vaping is it is an addiction. We don't want people to be addicted to something. It does rule your life, and it is something that's really hard to give up. But at the same time, what we also want to make sure is we've got the right support for people should they... So for young people, for example, when they are thinking about life choices, it's really important that we work with them to get our vaping programme right, our anti-vaping for young people programme right, because with all the best will in the world, I'd love to feel I'm down with the kids, Councillor Harrison, but I feel I'm not. So, but actually, and what I'll do is I'll bring Pippa in a moment to talk a bit about the inequalities piece and what we're doing with the young people. But I do think there is a degree of inequality there, but I do think we see it quite broadly. Whereas smoking, there is a huge inequality with smoking. Pippa will be able to be more clear on the evidence than I am on that, but I think that's still an inequality, but not as steep as smoking. But of course, that's where smoking started. Smoking started where everybody smoked, and now we've got a situation where it's very localised in certain groups. Can I just go on to your question before I bring Pippa in, because I don't want to forget the ICB question. It's a really important one. So The way that stop smoking services are funded is slightly variable. So most of the services, community services, are run by public health, so they're actually run by us, so it's an in-house service, and they're funded partly by the core public health grant, and also partly by something called smoke-free generation funding, which has been an incredible asset to us. It's allowed us to really expand our team. It's allowed us to look at where we can put people in different ways. Can we do things that are innovative? Can we go and work with employers? Can we do stuff that we could not do before because we've got that extra money now, and that's fantastic. At the same time, there was some funding available in the NHS to support stop smoking services outside of the local authority environment. So, in hospitals, so if you were a pregnant lady, a pregnant mum, and you were in hospital and you talked about your smoking, there was a service, and there is a service within that hospital to pick you up straight away, and then that would move you into the community service. And that's been working really, really well. And also at Kettering General and Northampton General, there have been teams and at NHFT as well. However, nationally and locally, some of that funding has been under threat. And I think, so whereas we know that most of that funding is continuing within pregnancy, which is vital. If you want to have a healthy pregnancy, you don't smoke. You know, and so many women give up smoking like that when they find out they're pregnant, and then do super well in terms of cessation, and the support is out there. What we need to make sure is if I go into hospital, if I went to Kettering General, for example, and they said to me, okay, Jane, you've got COPD or you've got this particular problem, let's talk about your smoking, that there's somebody in that hospital who can give me the right advice at the right time. And sometimes it's very context specific. So sometimes people have talked about the smoking several times, and that one conversation is what they need to move them into that next space. Some of that funding has either been reduced or is going significantly over the next few years. So what we're doing in public health is saying, okay, my job is population health. My job is to protect the population of people in Northamptonshire, North Northamptonshire. So what we've done is we've looked at, can we support the hospitals in a way that allows for those conversations still to go on, and we're going to be modelling that. So do we provide in-reach? Do our staff go in and do that in that setting? Or do we support them to look at different ways of delivering that? So we've got a couple of things that are going on. One of the things we're going to do is look at the art of the possible. So we've got a new member of staff who's going to work with us for a period of time, who's going to say, if we want the best offer across the system and we know resources are limited, this is what that's going to look like. And we're funding that as a proactive way of protecting our population and making sure we get the best out of it. If I'm being completely honest, some of our referrals from some of our healthcare providers haven't been where we want them to be. So actually, it's strangely an opportunity for us to rethink that. So what I'm hoping is we'll come out with a model that is either our services going in or another way, or we do different work together so that pathway is really smooth. What I'd love is for everybody, every healthcare provider, everybody in housing, every social worker, everybody to say to people they are working with, have you thought about stopping smoking? And for them to be able to say, do you know what, we've got a cracking service in North Northants, this is how you get in touch with them. If we could get that bit right, where everybody was having that conversation, that in itself would be a major step forward. I've probably diversed slightly on that one, but another passionate subject I'm passionate about. But I'm just going to bring in Pippa.
Thanks, Jane. So I'll just go back to that information about vaping. So the data that we have on vaping, particularly in children and young people, the best data we have is from at a national level, from a national survey. And the breakdown that we get, so that's sort of the level of vaping over time, there has been that steady increase, both in children and young people who've ever tried vaping. So that's just they've tried it once, they might not vape regularly, but they have tried it. And also current vaping, so the number of children and young people who do vape regularly. What we have seen, though, at that national level over the last 3 years, 2 years, from about 2023, is that has started to plateau. So at the moment, The level of children and young people, sort of 11 to 17, who've ever vaped is about 20%, and that's plateauing at that level. And the level of current vaping, so children and young people who do it often, is at around 7%. And we've also started to plateau at that national level. So we do have the shoe survey, which happens every 2 years at a local level, and that's where we can get a bit better insight to what's happening at a Northamptonshire level. That national data, the sort of breakdowns we get in terms of inequalities is mostly by age, in terms of what they give us, and that just shows us that it does increase with age, as we'd probably expect. But it's still quite high in that 11 to 15-year-olds, so 16% haven't ever vaped and 5% currently vaping, and that goes up by 18 years old to 28% ever vaping, and 15% currently vaping. So that's the sort of breakdown we have at the moment.
Thank you, Councillor Harrison. Thank you, Pippa and Jane. Any more questions from the members? Councillor Davies, go ahead.
With all the interventions, I smoked for 33 years, and I just decided wheezing in bed one night, I'm going to stop. Now, I would watch all the adverts with people with oxygen and then all the pictures on the cigarettes and everything else. Never deterred me until I decided I want to quit. So with all these interventions, have you got any data of how much preventative measures work? Because peer pressure and all that wonderful stuff, you know, you could say to them, honeycomb lung, glycol in the juice, you know. But if their friends are doing it, try this watermelon. I mean, watermelon vape. Wow. But do you know what data is that actually prevents them from doing it? Because the next hand, you know, somebody might go, you're spot on, and then the next day they're, try that vape.
Prevention is complex when it comes to this because, I mean, smoking is quite similar to vaping. So we are, as human beings, influenced by the people around us. We absolutely are. Going back to your earlier point about adverts and what happens, there has been evidence to suggest that does work. And the reason we have the plain packaging and then the really unpleasant packaging is from research that was initially done in Australia, which has shown that does have an impact on cessation. But we need lots of different things to have an impact. So there's no single thing that stops people from smoking. And you're hugely in a minority because very, very few people wake up one day, stop smoking, and then they never smoke again. Most people need support. So that you are unusual in that, but it's amazing. You are our poster person for smoking cessation. It's fantastic. You see, and I bet you feel better. Hooray! This is great. But I mean, some of the research. So I did some research myself a few years ago with people who smoked and who'd given up smoking, and it was really interesting because we're all different about what drives us. And for the two things that really drove people were their family. So you remember the advert where you saw children inhaling smoke, sat on the stairs and inhaling smoke, etc. People were saying, I don't want that for my children and I don't want them to grow up to be a smoker. The other thing was their pocket. So people quite often will go, actually, I had no idea how much I was spending on cigarettes, and that really does influence people. It's quite a good way of talking to people, a bit like when we talked about return on investment. If you can quantify to somebody, actually, if you stop smoking for 3 months and you're smoking 20 a day, this is what that looks like in terms of cash. For some people, that also helps, but we need different approaches for different people. Your point about normalisation is a really important one. So, and Pippa's going to talk a little bit about the work we're doing in Corby, but what we've really seen from people we've spoken to is it's not seen as an issue. We're not getting, people who are smoking aren't saying, actually, I really want to give up necessarily, and it's not something that people are talking about. And when you look at the life expectancy gap in Corby, for example, so we have some communities where there is a life expectancy gap quite close to them, smoking is at the heart of that. And yet we're not talking about that. And what we really need to do is work with our communities to say, what else could we do that could help you? Part of it is getting the service right, but part of it is also understanding that for some people, they might wake up one day and stop smoking. That's amazing. But that's not the same for everybody. We need a really good offer. In terms of prevention for vaping, I feel that feels very early days, if I'm being honest. I don't think I do see a huge amount out there in terms of prevention around don't vape if you're not already a smoker, etc. But did you want to add something on that one, Pippa?
talk about stop smoking service. I think just to add on as well around the stop smoking service, so that's in the report, and what that offers is 12 weeks of support, so that's behavioural support, and then access to NRT or vapes, if that's helpful in someone going through their quit. What we do have at the national level is evidence that that model makes it 3 times more likely to people to quit. So I think that message is, if people do want to quit and they're ready, that service is there to really help them. So as Jane said, often people can't quit by themselves. We know nicotine is really addictive. So if people are ready and they need that support, that service is there for them, and it is shown to make that quit more likely and support. So I think that's just one thing that we wanted to highlight, and look at other ways as well. I think that what we have found coming out of some of our work in Corby is what you mentioned, is that people have been able to quit, but they're in an environment where smoking is quite prevalent, so that they've not been able to sustain that over the long term. So some of those findings are coming out of there is us thinking as a service, how do we support people to maintain that quit over the long term, and how do we work with communities to try and change that culture and create more environments that are smoke free, so people who have successfully quit can keep that success.
How many shots at or bites of the apple do people get? Because I quitting so many times.
That's exactly what I was going to come
So if they get their 12
Davies.
weeks and then 12 months later they start again, and then do they get multiple top?
Yes, absolutely. And in fact, we have our wonderful Ollie, who essentially rings people. So people get referred to us, and it's a very quick turnaround in terms of response to our service. And part of our intervention is our wonderful Ollie, who mans the phones. And the amount of times I will hear him say, "That's okay. I know you know us. I know." And sometimes Ollie knows people, because people have been through it a number of times. And for some people, it's been, I felt I nearly got there, and then something happened, and then, I'm back to where I was. And people feel a sense of shame almost with that. It's really important that there's 2 things I would say. This is a super addictive thing. And for people who've never smoked, it's really difficult to understand how hard it is to give up smoking. So if people like yourself who have given up smoking, that's something to be enormously proud of, because it's not an easy thing to do. In the same way, it's not easy to if you're somebody who's got any sort of addiction problem, whether that be food, whether that be drugs or alcohol, stopping is really hard. And we will always be there to support people, whether it's their first attempt, whether it's their second, third, whatever it is. We are there to support them, because we know that for some people they do need more than one bite at the cherry, as you said. Other people they don't. But we don't judge at all. We are there to support people. And for some people, they might have said, well, last time I just had the behavioural support. Maybe I'll try something else this time. That's fine. That's absolutely fine. People need to be able to think what's going to work for them.
Thank you, Councillor Davies. Since the conversation has organically moved on to prevention, I'd like to offer Councillor Howells the opportunity to ask some questions next. We'll come back to section 2 afterwards. No, you're not being declined. Is it about prevention and smoking? Go ahead. Is that okay, Councillor Howells? Yeah. Councillor Pingelli.
Yeah. The issues we have in smoking in Corby is massive, and I recognise that. And my mum and dad, when I was at home growing up, used to smoke one fag after another. My dad worked at Lodge Park Sports Centre. If anybody knows out in Rockingham Triangle, you went in there, and with his colleagues, it'd be just full of smoke. You think this is the healthiest place in Corby, there's smoke everywhere. And my mum died when I was young, and my gran did all through smoking. I understand the issues we have. But what worries me is we've known these issues for years and years and years, and you see some of the figures of, in 2015 there was 32% of people in Corby smoking, in 2019 it was 27.5, where we came top of the list again. What we're getting now is, and I know and you work really, really hard, and I know understand your team work really, really hard, but we're now lacking on the detail of the percentage of people in Corby smoke, and also the different estates, because what you've said quite rightly, I know that's probably another report deeper on, but all I can go by as a scrutiny member is what's in our report. And how do we tackle that? Because we've done so much stuff in the town centre as a borough council. I'm going back 10, 20 years where we had vehicles, we were saying this is wrong, you've got to give it up. And we're not winning that war. Why are we not winning that war? And when you see all these vape shops all over the place, you're wondering, why is this figure on smoking not coming down? And there is a danger with vaping as well. I remember when I was younger, and my family lived in Nottingham, and John Player's cigarettes, you say it's healthy, smoke is healthy. We're telling people to vape, and the amount of people vaping now, is this going to be an issue that we've got in 20 years' time, and you're coming here and you're saying, look, we didn't really recognise vaping, now we're getting all these people dying early because of vaping. So how do we tackle it? And it's a worry for people that, I know how hard you're working, but we're just not, why are we not hitting it? Why are we not doing, and what's happened with vaping now as well, people are telling me that people now are adding tobacco into the vapes. So the good thing about vaping was you didn't have tobacco in, or I've never smoked, but now I'm being told that they're adding tobacco into it, or not tobacco, what's nicotine into it, that's the cause of cancer anyway. So how do we bypass that as well?
Quite a few questions there. But I love the fact you say it's a war. I do think it's a war. I think you're absolutely right, it's a war. So rates in Corby have come down. They have come down, but they haven't come down equally. So the rate for Corby overall has come down, and we know in some wards in Corby it's come down. And where we get that data from, it's super hard to get it. And it won't be entirely the most accurate, but we get something from the NHS on what's called QOF data, which is data that's from general practice. That's not entirely accurate, but it gives us a good sense of what it is. So we do know, like Kingswood, for example, we know that that's probably, I think it's the highest, isn't it, in Corby. So we do know that. And I'm going to bring Pippa into what we're trying to do, because what we're trying to do is ask for the community to help us with the answer. Because you're absolutely right, it feels like we've done everything we can do sometimes. With other things we can do, like we want to move to be able to provide some different sorts of drugs that you can take that need to be prescribed. There's things like cytosine, for example. Things we can do. But what we need to do is understand communities as much as possible with that. So before I bring Pippa in to talk a little bit about that, just to talk about vaping. So you're right, vape shops are everywhere. They are absolutely everywhere. And you'll also know from in the report, there's been a huge amount of work we've been doing about seizing illegal ones, because there are a huge amount of that. What the Smoke-Free Generation is bringing in is legislation around they have to be licensed. That will help. There will be something in that. My concern is that there has been some stuff in the national data, and it's not something I'm aware of locally, but certainly nationally, around people adding substances to vapes. So that's a huge issue as well. We don't want that. My issue with anything is that addiction is something that I would not want on anybody, really. So nicotine is the addictive substance. And it's the tar and other products in the cigarettes that cause the lung damage. But I don't want people addicted to nicotine either. And my personal view on that, or the view from public health, is at the moment it's an aid to help people who are smoking, because the evidence on smoking is you've got a 50-50 chance of you carry on smoking, that is going to kill you. We don't have that evidence for vaping. Doesn't mean we won't have some evidence of harm sometime in the future. Who knows what's going to happen? We have to go with the best evidence of what we've got now. But I'm going to bring in Pippa, because I think your question is very pertinent. Is when we've seen, for example, in Oundle, we've got 9% of people smoking, and we're so different. Is what are we doing? What I'd also say is just reflect on your family. I come from a family where everybody smoked. And you would go into my grandma's house, who was unbelievably still alive at 102 and living independently. But everybody in there smoked. What was really interesting, it goes a little bit back to your point as well, Councillor Davies, is that when a few people stopped, other people stopped, and it became an abnormal thing for the family to do, and now nobody does. And it's tapping into that, isn't it? Is what do we do to change that culture so it doesn't then just carry on generationally? Do you want to talk about what the insight work?
Yeah, so I think we had that approach as well in saying, okay, the Stop Smoking service has worked for some people, but it's clearly not working for some of our communities in terms of what we'd offered. So part of the work we've been doing over the last year is a project at that community level through the local area partnership. So we're working with Corby Local Area Partnership, and there's a task and finish group set up within that so that we can work with the community and with stakeholders who are working with the community to understand, okay, what can we do differently? We know some of the interventions that are effective, but how do we work with the community? What are we missing to support you? So part of that work, there's been some review of all the data, and then we've also had a provider who's come in and done some insight gathering work. So over the last 6 months, they've been doing stakeholder interviews, so we try to reach out to whether that's key stakeholders within the Corby community, and so that came from that task and finish group. They've been then holding focus groups, so with members of the Corby community who smoke and who also don't smoke, to get that wide view of what are the perceptions of smoking, what are the attitudes to smoking, what are the understanding of our Stop Smoking service. And they're also now still live at the moment. The end part of that is a survey. So they're trying to collect data from lots of different places to understand. So we're still waiting for the final report that will be due early October. But we have some early insights from that. Do you want me to go into those now?
If that's okay.
If that's okay. So some of that around the sort of smoking behaviours and influences, so people have reported that they mostly started smoking young, often due to peer influence or social norms, and they generally feel neutral or positive about smoking. The health risks were well known, but the perceived benefits, so whether that's relaxation or social bonding, overweighed those perceived benefits of quitting. We do know it's linked to routine and manual work, and that's a national trend as well. So there's some, the type of work, having breaks, that it's linked to. In terms of quitting smoking, the feedback we got was many people had tried to quit before but then returned to smoking, as we'd said, because they found it hard in their community over the long term to sustain that quit. The most quitters, similar to what Jane said, they were motivated by their family, so they were motivated to quit related to their children and the harms it might have on their children. So that's helped us understand a bit around what we might need to do differently. And then we also learnt a bit around the messaging. Smokers and people in the community were a bit defensive about being told to quit, and so we need to look at our messaging and be there when they're ready to quit and be there ready to support them. And do a bit more in terms of highlighting what our service offers. So there was probably not an awareness of everything we offered. People often thought it might just be NLT and were more interested when they heard the full offer. So lots of different insights. The next stage of that, once we have that final report, is in early November. There's a co-production workshop to then turn those into how can we adapt our service and pilot those. So again, that's through the local area partnership, but we welcome anyone else who wants to join. It's not closed.
And I was going to, on a note, Councillor Pengelly, for example, you're very embedded in your community, and I know that you're quite passionate about this subject. We would love for, if you wanted to be involved or anything.
I work in the daytime, which makes it difficult
for
me to consent.
We can always bother you in the evening. No, in all seriousness.
There's not even I just can't get to them. Just two other little matters then. You touched on alcohol, and alcohol is a massive killer. We're aware of that, and the more people, and we're all at an age where people used to go to the pub and drink, more people drink at home. And I was at a seminar about a year ago where they talk about the dangers of women drinking. You're having a bottle, I'm only having a glass of wine and the glass is about that big, and the issue women are having with drinking alcohol as well, and falling over and dying because of other issues as well. How do we tackle that? Because when you see people in a pub, you can see people drinking, you can say, I'll tell you what, mate, you're drinking too much, Mark, or whatever. When people are home drinking, you don't see it. So how do we tackle that? And the second part, so we'll go all off as well, is you talked about deprivation and something, you talked about mould in houses, and there's other issues where people haven't got the proper houses, living in bed sits, or living in three or four to one room in HMOs. How do we tackle that? Because that's got to have an effect on people's lives as well, and the mortality. So how do we tackle that as well?
Well, firstly, you've touched on one of my favourite public health topics, which is alcohol, I've done a lot of work in this area. It's passion of mine, alcohol is an insidious thing that when we talk about drugs, people don't think of it as a drug, but it actually, as you point out, takes a lot of lives. Now, interestingly and sadly, COVID made a big difference to mortality from alcohol in this country. It also changed the face of who we saw going into hospital with alcohol-related conditions. So I did some research in another area of this country which showed that actually exactly what you're saying, there was a difference. So quite often people, when we think about people who are getting liver disease, there is more likely to be men, for example, and men of a certain age, but we were starting to see more women. We were starting to see people from more affluent areas than we would normally see. So things changed. COVID changed a lot of people's, our mortality rates for alcohol across the country have gone up since COVID. Now, you raise a really important about home drinking that is more hidden. But what I would say that one of the major things is that people often are not even aware that their drinking is at a level that's going to cause them harm, because you don't actually have to be drinking 70 units a week, which is generally what we look at dependency, 70 units a week. So one bottle of wine is 10 units, okay? 70 units a week, people think that's terrible, but actually, if you're drinking 30 units a week, that's still going to harm your health. And I go back to a point that I made earlier about wanting everyone to talk about smoking. If we had everybody talking about, just, whilst I'm talking to you, do you know how much you're drinking? It's an interesting one. People know that they shouldn't smoke, and they know that someone's going to ask them. Okay, with alcohol, it's not that straightforward. What we know straight away is that alcohol is ingrained in our culture, isn't it? It's a huge part of British culture, alcohol. It has been. It goes back thousands of years, actually, alcohol. And so we are not asked as regularly about how much we drink. And when we are asked, lots of us don't understand what units are and what that really means. And I used to carry around, this sounds very nerdy from a public health perspective, but I used to carry around scratch cards that were by an organisation that you could give them to people, and invariably people would pick up one of these scratch cards and think, this is a bit of fun, get their pound coin out, start rubbing it, and their face would fall as they went down that scale of realising that they were drinking more than they realised. They were drinking sometimes every day, when they'd not even thought that one glass of wine every day was turning into something more problematic. And they were actually at a level where they were harming their health and probably needed some intervention. The amount of people I've done that with who had no idea. So we've got the people who don't have any idea, and we need to educate people on that. The other thing, we need to get more people into treatment. So we have treatment services. For some people, what they really want for alcohol will be different to other people. Some people need detoxification, and we provide that service. We've got services that detoxify people. Some people want to go into something like the 12-step program, which is Alcoholics Anonymous. That can work really well for some people. Other people want a different offer. It's a bit like smoking. You've got to be responsive to the offer. What we know about alcohol, and we've had a big push locally on trying to get more people into treatment, is we have something called a penetrance rate, and that is, of all the people who need to be in treatment, what percentage generally have we got in treatment? And nationally, and it's no different here, it's about 20%, which means there's 80% of people who need treatment who aren't getting it. And that is a really difficult thing. And you are absolutely right, Councillor Pengelly, that there are people we are losing because their drinking is hidden. And, for example, we know that can be in older people as well. There's some research evidence that in older people that can be really quite hidden. And there are people that don't know how dangerous their drinking levels are until they turn up in hospital for the first time with liver disease. I've seen this in the data. I've done lots of research in this area. We've got to do something different about having a conversation earlier, making sure people understand where to get the treatment, and get people to understanding that alcohol, no level of alcohol consumption is safe, but you can reduce your risks by staying below 14 units per week. And that's not easy. We know a bottle of wine is almost that. So we know it's not easy, but there's things we can help people with to bring that risk down. And for those most at need, get them into compassionate, personalised treatment, which will make all the difference for them.
And housing.
Oh, I forgot. Sorry, I got carried away with my favourite subject, but you're absolutely right again. So I talked about mould and damp as a particular example, but cramped living conditions. I mean, let's go back right to the beginning of public health. What really was a problem in this country was TB and cholera and things like that. And TB and cholera were due to overcrowding. So we know that living in cramped conditions is not good. It's not good. It's also not good for your mental health either. In my view, I think this is a general public health view, is that what we need is affordable housing that is of a decent standard for people to live a life comfortably. So we know, for example, that living several people to a room is not good for you. It's not good. And we do sometimes see nationally families in that position where we've got that. I'm a trustee for a homelessness charity, for example, and we know these things are happening. We know these things are happening, but we've got to have the right amount of housing available, and that's got to be responsive to what the local population needs. And today at the One Council event, we were talking about, this is a staff event, we were talking about that's going to be a real focus for us, I think, going forward, is making sure we've got the right housing offer. We've seen the single biggest rise in population in between those two census periods, 13%, it's huge. We've got to have the right housing, it's got to be affordable, but it's got to be decent standard.
Thank you.
Thank you, Councillor Pengelly. So we'll go over to Councillor Howes now with prevention and early intervention.
Thank you, Chair. I'd like to sort of carry on the vein of talking about people who potentially don't want to stop, full stop. Obviously, if somebody's tried to stop, obviously there's already a starting point there. You mentioned, which I hadn't really thought about before, about people who just don't want to stop. They don't see a problem with it. They don't think it's a problem. They actually think it's beneficial. So what specifically are you guys doing in that for people like that? Obviously, they're disengaged from the mainstream services, I would imagine, and the aim, I assume, is to get them engaged. So what sort of thing is happening there? And also on sort of the opposite way, what about people who are underserved, so rural communities and things like that?
So you're right that some people don't want to stop, and that is not just for smoking. That is for people who've got other sorts of addictions. So there will be some people who are, for example, drug users, or people who are using alcohol in a harmful way, who don't want to give up. What you tend to find, though, there is something that happens that changes somebody's mind. So, for example, a lot of my colleagues, being a public health consultant by background, a lot of my colleagues are GPs and hospital doctors, and that goes back to my point about having the right question, the right conversation at the right time. So I've spoken to so many GP colleagues of mine who it's when somebody gets that first diagnosis of COPD. So they get a diagnosis of chronic obstructive pulmonary disease, which is a horrible disease, something I would not wish on anybody. And sometimes that's the point when they think, right, this is where I want to give up. We can't force anybody to give up. Okay, we can't do that. That's unethical, and we wouldn't do that, obviously. But quite often it's at that point there's something that happens. So I mentioned earlier, for some women who've been heavy smokers for some time, they will get pregnant, and I think it's about, I don't know why, I think it's 45%, you might correct me, will just stop smoking really quickly, because that is that life event that changes their mind. I have seen it in people who've got a family member who's been diagnosed with lung cancer, for example, where they change. So we have to have the offer there at the right time. So that's about having the offer in different places. So one of the things that Pip has mentioned is, if, for example, that somebody starts having these thoughts, I think perhaps it is a good idea to stop, but actually the main place that they're spending time is at work, well, why can't we have work-based cessation support? That's something we could do that's different. So we have to always be there at the right point, really, to do that. We can't force anybody, though, of course. That would be completely wrong and unethical. The second part of your question, I've slipped my mind. Rural communities. So for rural communities, it is obviously a lot of our services there's a mixed model. Some people like to be face-to-face for smoking cessation support. Some people, actually the majority, like to have a relationship with their advisor but over the phone. So we do a lot of that, but we also want to get out to our rural communities, because one of the things is as Pippa mentioned, if even in areas like Corby, which are big conurbations, aren't they, we've still got people who aren't aware of our offer, We need to get out to those rural communities and make sure we're making that really clear. One of the things we're talking about at the moment is having greater involvement with our parish and town councils, for example. How can we use them to be a really good way into communities? And we're also looking at co-locating things. So we had a fantastic conversation, didn't we, Pippa, earlier this week, where somebody was talking about how their local GPs do this great big vaccination drive for flu, and loads of people are in the same place. It's a very rural community. We'd be crazy not to want to go out and talk to those people at that time and say, whilst you're here, I mean, it might be, for example, when did you last do your blood pressure? You know, or have you thought about this, have you thought about that? But smoking can be part of that. So what we see it as is a kind of a real move into letting people to know what's available, but having things that suit people. So if it was, for example, that a rural community really wanted face-to-face, we would respond to that. What we tend to find people like to be on the phone. That works very well for lots of people, but it doesn't have to be that. Did you want to add anything about rural communities?
I think just to mention what you mentioned earlier, that we are, as a public health team, undertaking a rural health needs assessment at the moment. That's to help us draw out, you know, what the main health challenges are or health needs in terms of public health support as well within those communities. And I think just on that, in terms of getting out into more rural communities, one of the ways we've used the additional money in smoking, because we have more advisors, is open up another face-to-face clinic in East Northamptonshire. Because when the team did a review, they recognised in terms of that geographical coverage that was a gap. So I think we're always working and trying to do that where we can.
Thank you. And going back to sort of the start then, so prevention. What's being done in areas like smoking, cessation, healthy weight, mental health, and in things like... So you mentioned the statistics, I might get these wrong, but 20% of people have tried vaping and 7% people currently vape. If the 20% was lower, do you think that the 7% would also be lower? So i.e. if people didn't try it, they wouldn't, you know, continue. So what's being done about preventing you know, people trying it in schools and things at the very, very start of the journey, as it were?
I'm going to leave Pippa to talk about the prevention piece for smoking and vaping, because there's a lot of work going on in that area, but you're right to raise all the other areas that we're trying to focus on as well. So if we think about healthy weight, for example, so we know that we have an issue around childhood obesity. So we do know that we have too many children who go, particularly at year 6, are too heavy, really, for their age and their height, etc. So we need to do something different on that. And that is something that we're really tackling head on, because what we want to be able to do is offer more family prevention type approaches. So we want to make sure we have, so the way that prevention works, you have a universal layer. So you have a primary prevention of stuff that you might do to try and stop a problem from starting. So if you think about alcohol as a classic example of primary prevention, things that really influence people's alcohol intake is accessibility and price. So nationally, you'll see big debates around minimum unit pricing and all that sort of stuff, and all these that at the primary prevention level. And you'll have seen one of the posters I used to show my medical students was there was a delightful poster a few years ago that was a pint of sick, best way to put it. And there was things like that which were part of that primary prevention thing, saying not feeling so great today, are we type approach. And there's really great posters actually about breast cancer risk and alcohol. At a secondary prevention level, that's when something's happened, something started, like someone started smoking or they're drinking harmfully, and we need to do something different. So from a smoking perspective, that's when our cessation services come in. From an alcohol perspective, that might be making sure that people understand their alcohol levels and that they get treatment if needed. And we work a lot at that particular level. So from a healthy weight perspective, what we need to do is get the best start in life for children, actually. But you also need to make sure that we don't have food deserts, healthy food deserts as well. That might be a phrase you've heard before. So where we have communities where we have very little access to healthy food, we often see a lot of access to unhealthy food. And there's new legislation that's coming out around fast food takeaways and things like that. As a council, we could look at that and do something in that sort of space. From my perspective as well, the best start in life is a huge opportunity. So you'll know that family hubs are really getting some momentum locally, and the family hubs are working with a whole range of different organisations, including public health services, to make sure that when a family is having a baby, that we're getting the best information about nutrition, about what to do to keep active, about what to do to feed your baby. It's not easy when you have a baby. I always think that people think that suddenly we all go, so we've had a baby, there's no manual for it. We need support, we need help. So that from a prevention focus type approach is really important. From that point of view of what do we do if a child is overweight or a family is overweight, I'm going to leave that to Pippa because we're doing some new work and new services around that. But again, it has to be joined up. All of this has to be joined up. We've got an amazing Healthy Schools team. Not everywhere has a Healthy Schools team. We've got a really active one. Most of our schools are signed up to that. The stuff that's going on in our local schools around healthy eating, physical activity, that is going to make a difference. Toothbrushing is a classic example. If you get children brushing their teeth, and supervised toothbrushing, and it's something that we're involved in, the public health team, in terms of providing, people will say, isn't that going a bit far, brushing a child's teeth? Shouldn't that be a parent's job? Shouldn't this be, is this not nanny state, is something I've heard in relation to toothbrushing. It's the most simple example for me of a low-cost intervention that changes things. If you've got a child where the family is not regularly brushing their teeth, and I'm from a family of teachers, and I've worked with a lot of my friends and teachers, I know this happens, okay? I know that not everybody has the same regime around oral health that we might have, or your neighbours might have. It's different for some people. But if you say to that child, here's your toothbrush and we're going to show you how to brush your teeth effectively, it costs so little to do that. They will teach their children to brush their teeth. That's the sort of approach that we need, because small, often simple interventions make the biggest impact. So I'm going to bring in, do you want to talk about healthy weight and some of the prevention work?
So I think healthy weight is definitely a topic that is being looked at a system level as well. So we're engaged through those forums. I think in terms of that prevention work through the Healthy Schools team, as part of the health and wellbeing strategy, there's an area of focus and a steering group who's looking at that in terms of what activities will be effective in that place. We know it's a bit more for adults when we're trying to do that prevention work or support people who want to lose weight. There's more evidence around what's effective and what type of models work. We know for children and young people it needs to involve their families as well. And there have been different approaches tried, and it's still trying to find that model that really works and is effective. Some of the work we've been piloting is through some of what public health funds. We fund a sort of Grow, Cook, Eat project, which works to help people develop their cooking skills, understand how to grow food and just get more familiar with cooking and growing. So we have been piloting a bit of a project through there to see if that's a way that we could support families who want to do something about their children and young people's weight. So it's quite early on, but that's the type of work we're looking at in terms of trying to support people to build those skills that then will help them go forward. And I think for healthy weight, what Jane's already mentioned is really important, is the environment, that food environment and the food network. So we at Public Health are engaged in there's a really strong food sustainability network in Northamptonshire, and that's trying to look at some of those wider factors, what sort of food is available to people, and is that affordable? So I think that has a really big impact on then people's ability to produce good, healthy meals for their family and their children.
Thank you.
Councillor McLean.
I know this seems like we're harking on about smoking. A few decades ago, when smoking programmes came online and we had patches and chewing gum and sprays, do you feel that introducing vapes is just going to move one person from one addiction to another?
I think the evidence that we have around vapes is that we know that they're not risk-free. So if people don't smoke, they shouldn't vape. But for people who do smoke, because smoking is so harmful, vaping at the moment the evidence suggests is less harmful. So it is a good route in terms of that harm reduction of moving people off cigarettes into, although they're still addicted to that nicotine, into a place where they're not having the full harmful effects of smoking. As Jane said, we are in public health led by that evidence, but always reviewing that. So where there are changes at the national level in that guidance, we would respond to that. We do see, that's not a choice that everyone chooses. Although we offer vapes, it's not a choice that everyone chooses. Lots of people choose other ways to stop smoking, and we monitor that as well to understand what the level is. So I think whilst it is a choice that some people make and it helps some people, it's not the choice that everyone makes. So the use of nicotine replacement therapy is still really high. People still choose that, and some people just that behavioural support. We know that combination is key. So I think that's probably the message around vaping at the moment.
And just to say that patches are still very popular. Yeah. So and they are still nicotine replacement therapy. They've still got nicotine in them, but it's about taking away the smoking element. And it's horses for courses, but certainly we see a lot of people who don't want vaping, and we don't push it. We don't say this is what we think is a great thing for you. It's up to, we give people the choice and say, what do you want? And we do have quite a lot of people who just want behavioural support. But as Pippa said, the most important thing for us is to be on top of the evidence all the time, to make sure that one of the things that we're interested in at the moment is that we're talking about some of the prescribable things. So there are drugs on the market that are quite new, that look like they could have some really good evidence for stopping people smoking without any of those other things. So we want to make sure we're on top of that and we're ahead of the game and we're able to provide that. There are some complexity of that because it's a prescribed medication, but we're working with our partners to be able to provide it because, I mean, ideally, that would be great. If that was something that really worked for lots of people, that would be marvellous. But we do at the moment need to have an evidence-based but broad offer.
Yeah, I think still on that vein, I mean, I smoked for a very short time many years ago and just stopped, like the councillor Davis there. But when I smoked, I always thought it never tasted that that good. But what you find is now with the vapes and all the flavours, do you think that the flavours are masking the fact that it is addictive and maybe bad for you? And is there a place maybe for vapes using government legislation to take the flavours out of them?
So that has been looked into, and particularly into relation to children and young people. So at a government level, at a national level, there's been research into what flavours are most used by children and young people. Learning a bit from smoking as well, because that was also used in smoking and cigarettes in terms of masking the flavours, and those were then restricted. In the new legislation that is coming through at a national level, that is one of the proposed changes, that it will reduce the amount of flavours that are available for vapes for that impact. We will probably most keenly feel it with children and young people, which is a really positive thing. So yeah, it's definitely known that does have an impact in terms of what is popular with people, particularly with children and young people.
And I think that it's aggressively marketed towards young people as well, which I think is absolutely wrong. And I often give this example. I'm very open about this. I'm a director of public health. I found what I thought was, can you remember the refresher sweets that you used to get as well? Yeah, I don't think you get them anymore, probably pull your teeth out. I thought, there's one of those refresher sweets on my son's floor, and it was a vape. And it smelt like a refresher sweet, and it was absolutely the way it looked, the way it was clearly marketed at young people. I must admit I did have a slight paddy and threw it out the window for being completely honest, but then it went into a dustbin, etc. But it was marketed at young people, and it's something we should all absolutely stand against, because we don't want our young people addicted to nicotine. And unfortunately, that's the way this has been going. And I think it is a really welcome move to saying, actually, let's do something about the flavours, because it is, for some people, an attractive thing. I mean, you can remember, some of you might remember menthol cigarettes. Can you remember that? They were very popular. They got some people into smoking, didn't they? We don't want that. We don't want people doing this. So I think it's a really important point.
Yeah, I think if we made them broccoli flavoured or cabbage, I think maybe we'd stop then. Thank you very much.
Thank you. Just quickly, you touched slightly on legislation and whatever. I think really we need to look at, and I know it's probably not your bag as such, but the licensing of some of these vape shops and even properly licensing the sale of cigarettes, because I don't believe they need to be fully licensed at the minute, because especially in next year when the tax comes in and whatever, your genuine vape sales shop who is not going to sell them to under 16s and whatever, they're going to all be put out of business by the bloke down the road selling the counterfeit ones and the counterfeit cigarettes, which we know not what's in them at all, and they'll be out of business. They'll be selling them. We'll be back here in a much worse situation.
Hugely important point, and you'll have read in the report that we're doing a lot of work. That this is already here. Okay, counterfeit cigarettes are already a problem. There's no doubt about that. And you'll see there's been a huge amount seized through Operation Stop. So that's a joint venture between Public Health and Trading Standards. And you're absolutely right, we don't know what's in them. That's something that's really important. We also know that cigarettes are heavily taxed. And so counterfeit cigarettes and cigarettes that have been bought in illegally, we're not getting the tax revenue on that. And that's a problem in terms of healthcare, because smoking costs a lot of money to the healthcare system. In terms of the licensing, so that is something that's coming in. And what I think, my understanding, and Pippa might correct me on this, is that under those proposals, local authorities will be able to keep funds that they take from finding people breaking licensing rules and doing things that they shouldn't be doing, and that will allow us to have staff to do more of that. So we can almost recycle that money into our prevention activity. But you are right, we have to be on top of that all of the time. Counterfeit cigarettes, huge problem. Not a problem that's going away.
Yeah, and that's what I say to you, that vaping is going to become exactly the same, because as soon as the price of legal vape stuff becomes taxed, there's going to be a bigger difference in between the two. And by licensing it, we can restrict the amount of licences. We say you can only have X amount of licences in Northamptonshire.
Yeah.
It helps to stop our high streets being full of them.
Definitely, and the licensing is coming in, which is really helpful. That is something that the government's bringing in. But also just to say this is already a problem. So through Operation Stop, I was talking to the teams who had seized huge amounts of counterfeit vapes. So vapes that we didn't know what they were, basically. And they were, what was the cheapest one, Pippa? Was it £1.99 or something? Hugely cheap. So we're already fighting that battle. But you're absolutely right. Licensing will help us with that. What it will also do, if I'm understanding it correctly, will allow us to gain some revenue that we can bring in, so we can be on top of that even more, which is a really welcome move.
Yeah, that's really good to hear, because it's really important that you help to push that along and make sure that legislation is in, because that's the only way we're going to have any effect on that. I will say I'm a vapor myself, so...
Yes, and when the smoke-free generation, so part of my job as an independent DPH is as an advocate. So I will advocate for things at local and national level. So, you know, I will write and give my views on things like the smoke-free generation bill and say support of that. And that's really important. We all have a job, don't we, in role in advocacy. And part of my role is to say, actually, exactly what you've said. We need to be really clear that there are things out there that we don't know what they are. We don't know what the dangers of them are. They're incredibly cheap because, like many things, the price of something does drive how much people use it. Cigarettes are so expensive now, aren't they? They're hugely expensive. But we know that people will be drawn to a cheaper offer, so we need to be super on top of that. Yes.
Councillor McLean.
Yeah, can I just ask a quick supplementary question? Do we employ mystery shoppers to go around these places?
So that has been part of Operation Stop. So what Operation Stop has brought, so that's that partnership project that's been ongoing between Public Health and Trade and Standards, is a series of enforcement work, so test purchasing. So there has been a programme, that's what Jane was talking about, where the seizures have come from, where there was a series of test purchasing, so sending the mystery shoppers into shops, and then enforcement activity afterwards in partnership with the police. So that has been a key part of that. That's also been data driven. So we used, the teams looked at where the reports came from. They did hot spotting, they looked at the data, and then they were able to target that, because it is resource intensive, both in terms of the time from trading standards and from the time from the police. So what we're hopefully, we're learning from Operation Stop are effective ways to do that. So with the limited resources that are available, that can be really targeted and effective. And where possible, there are options that we can do in specific circumstances where illegal products have been found, where someone also has an alcohol licence. There is a route there for the police to review that alcohol licence, and so Public Health, we have made representations at those before. So it's a whole package. We're also doing some work as part of that to deliver a comms campaign to make it more easily understood by the public about where they can report concerns. So we've done some work that's joint as well between Trade and Standards and Public Health.
Yeah, thanks very much for that answer. That's very good.
Thank you. Councillor Pengilly, do you have any questions? Your microphone's on. No. Members, are we happy to move on to the next theme, which is the role and impact of local area partnerships? Paul Brooke, do you want to take the floor on this one? Sorry, Councillor Brooke.
Oh, yeah, back in the hot seat. Okay. How are local area partnerships being supported to deliver on the public health priorities at a community level?
So local area partnerships, we work really closely with them. It helps actually that team is in our directorate, which is great. Some really good cross-working goes on there. So public health, and I mentioned this earlier, this has got to be community driven. So sometimes things that are coming up through the local area partnerships that are priorities are, for example, around drugs and alcohol, for example, that's come up quite strongly in lots of different areas. So we will support them in that. So we will say, okay, we might need to do some targeted work there. But we will also make sure that the local area partnerships are data driven. So each local area partnership, this is actually a really good resource for members, have got what's called an insight profile. So each local area partnership, a collaboration between public health and other bodies, have put together a really nice data pack for each of those areas. So it will show you things like levels of childhood obesity, levels of smoking, life expectancy, all things like that. And that's really important because we need to make sure that we are using the right data to support them in the right way to make sure that we've got that right. The other thing we will do is we will support them. So if, for example, an area feels very strongly that they've got an issue around drugs and alcohol, to use that example again, we will look at our service offer and say, is there something different we need to do there? That might be something like an outreach type model, or it might be just people want to understand more about drugs and alcohol. And in that case, our public health officers, quite often with the service providers, will go out to the local area partnership and talk to people. So we work very hand in glove with them. The other thing we offer to them, which I think is absolutely vital, is if they're doing innovative projects, we help them evaluate it. So it's really important as a council, we're all about efficiency. We want to make sure we're using all of the resources, whether that's NHS resources because we work so closely with the NHS, or local authority resources, that we're doing that in the most efficient way. So, for example, we've got a member of our team that sits on the panel that considers what projects might want to be taken forward, so we give them that view on there, and we also make sure that we give them support on measuring impact. Because the most important thing, as I mentioned earlier, we don't miss something that's great, or we don't invest in something that's not doing what we need to do. So that's how we work with them.
So that's like elderly as well, not just drugs, alcohol, blah, blah.
Whatever that is. So you do tend to find... So I use drugs and alcohol because, for example... Alcohol particularly has come up as from a number of different ones, but we might have people, you know, if the interest was in healthy ageing, for example, we're doing quite a lot of work. PIPA's doing quite a lot of work on that at the moment. Anything that we offer, we can flex around the needs of the local area partnership. And for me, that's getting into that space where we are working at a more hyper-local level. I think some of the issues we need to get right might be nuanced for different communities. And our communities are quite different, aren't they? If we look at some of our areas of East Northants, there's some huge areas of rurality there. We've got a different ethnicity profile, for example, in Wellingborough than we've got in Corby. There's differences, and we need to really understand those differences and make sure we flex the offer around that. But also, fundamentally, and something I can't believe I've not mentioned so far this evening, is one of our amazing assets in North Northants is our voluntary community sector. We've got a vibrant voluntary community sector, and one of our roles with the LAPS is to make sure that we're really linking in those services and those areas of expertise into our local areas. Lots of the stuff that we need to do is delivered by our voluntary community sector partners, so that's part of our role as well. It's also quite fortuitous that within our directorate we have all of that work around voluntary community sector, so it works quite well for us all to be in the same place, but absolutely that's what we do, is making sure we make use of that asset too.
Yeah, I see quite a lot of the voluntary stuff going on. I'm from Wellingborough, and we get quite a lot of that in Wellingborough going on. So that's yeah, quite important, really, I think. There's another thing I wanted to say here. Yes. Are there? I take it there are early signs, measurable outcomes from the lapse, as you mentioned. Intervention in the areas such as prevention and wellbeing, which is sort of slightly what we touched on, I think, really.
So where we are with local area partnerships, and I actually spoke to Nathan that runs that area of only today, actually, fortuitously. And there's a number of projects that are going on through the local area partnerships that have been funded by what we've mentioned before, which is called HIAA funding, which is actually NHS funding. Great partnership working, actually, between the ICB and us as an organisation and our voluntary community sector partners. And those projects are starting now. So I mentioned earlier that the most important thing is that we do two things. A, we have a really robust way of determining what we're going to spend that money on. So what happens is, let's say a project, so I mentioned a few projects, there's one that's been worked up around cycling, for example, for part of the physical activity work in one of the areas. We need to make sure that that is a really good proposal and it goes through a process. We don't want to overly process everything, because obviously this is about being reactive to communities, but it has to be consistent, it has to be fair. And then what we do there is, if that's funded, we help them look at what the impact is, because that's very, very important. Some organisations or communities who want to take things forward might need a bit more support in that space. They might say, well, how do I show whether investing in this has actually made a difference? That's one of our skill sets in public health. So it's really important that we offer that support and we offer that framework for what that looks like. So that's how we're working with them at the moment. It's very early days on those projects, so I wouldn't expect those outcomes for those yet, but what we will do is make sure, so I think there's a requirement for a 6-month check-in in terms of outcomes, and then they have to do an end of project report, which is not onerous, because we don't want to make it such an onerous piece of work, but it allows them for us to get an objective view, as objective as it can be, on impact.
Oh, right, okay. When you're teaching kids about cycling, do you want to tell them that there's more than one wheel on a cycle? Because they're always going past my house on the back wheel. So the other thing I want to say was, how are you? Which you slightly touched on again. God, I just got to turn that down. It's nearly blowing my ears off. Sorry. How is the council ensuring consistency, collaboration, and equality, resource allocation across the LLP footprints? But you slightly touched on some of that.
It is really important we get a really good offer for everybody. That's really clear. And there's obviously, I think 7 laps from the top of my head. 7 laps. And we need to make sure there's a really good offer for all of those. And some of those will be more well attended than others. That is the nature of things, isn't it? And we're always looking for how we can bring more people in for the ones where there maybe isn't as such a vibrant attendance as other ones. But they all follow a very similar offer in terms of support. So there'll be officers that work with local communities and work with our stakeholders. It's very consistent there. We have the same processes across those different areas, and then we have an oversight of that. So every single application for funding, for example, from a LAP, for a new exciting project for that local community, goes through a panel and it comes to me. So I see all of those. And one of the things that I always ask is, have we got good equity across the patch on this? Sometimes, and we have identified that there's some areas that don't put as many applications in. That's up to us to support people to put the applications in. Because sometimes that's a bit off-putting for people. They might have a brilliant idea, but they might need some support. So we do really take that quite seriously to make sure we've got the right offer. And also, some LAPs might be more active because they are doing lots more activity depending on who's a member of that particular group. But we need to sustain that and grow it, make sure we've got the right representation, but also make sure that we're getting the voice of communities really strongly through those. That's always going to be key, but certainly something that we do through a consistent approach from an officer level in terms of support.
Okay, thank you.
Thank you, Councillor Brooke. Are there any further member questions on the involvement of the LAPs? No? Okay, we'll move on to the next theme, which is community engagement and voluntary sector collaboration. So I'll open the floor to Councillor Lumsden.
Thank you. First, can I just say I think you're doing an amazing job. I love the passion behind what you're doing and the commitment, and you have my backing 100%. Often, I mean, you hear about prevention's better than cure, but when you do have to cure something, often somebody that's been there before is often the best way to help somebody else go through what they've gone through. So I'd like to know how the council's working with voluntary and the voluntary and community sector to support resilience and self-care at community level, and also how are local residents, particularly in the vulnerable and isolated group, being involved in co-designing health interventions?
Excellent question, thank you. And I think, so I'll start with the end of that question, if that's okay. So from a public health perspective, everything that we do, so for example, in the last 18 months, and we're fairly exhausted through this process, we've recommissioned loads of our big services. So our 0 to 19 services, sexual health, we're going through drugs and alcohol at the moment, health, all sorts of different contracts. And all of that is done with the voice of residents and service users at the heart of it. So what came to scrutiny previously, for example, was how we had redesigned and reimagined services for 0 to 11s and 11 to 19s. That was a huge piece of work where we involved lots of different stakeholders, so people providing services, people receiving services from lots of different groups. We commissioned particular organisations who had better reach than us. So we had some organisations who were really good at reaching some families, for example, that perhaps we weren't as good at reaching. So we commissioned them to do it because they had the better community links. And that's where our local VCSE really comes into that, Councillor Lumsden. We've got some brilliant reach into our communities and we need to maximise that. So we do have a very strong voice in that. In my view, co-production is a term that is bandied around a lot. In my 30 years of work, I know you're amazed I've been at work 30 years, but I really have. I wish people were amazed by that. I've ever seen true co-production done a few times. It's really hard to get it absolutely right, because really what people often talk about is consultation. And we do some really good consultation, and we do some really good elements of co-production, but we probably could be better. But certainly everything we do, and we design our new pathways, we do as much as we can to bring people into that. And that will include service users, people who are providing services, people who are advocating for people who use services. So we do that. And that's really important. In terms of the first part of the question about the VCSE, this is a topic that I think as a council we're really passionate about. So I've mentioned that we've got such a vibrant voluntary community sector, and to give an example of how that is helping our community, how these initiatives help our community, I think one of our best examples is a service that's called Support Northants. And some of you may be familiar with Support Northants. It's run by the voluntary community sector. It's funded partly by the Better Care Fund, but also by Public Health. And it's run by an organisation in Wellingborough, but actually what that organisation does is brings 172, who would have known there was 172 organisations in the VCSE around people, I've worked too long in the NHS, around people. So these might be people who are on a known to adult social care, and there may be people with a whole range of different needs. And that particular service wraps the different offers around that person. Some of it might be statutory services. So to give you an example, I had a conversation with a resident about a year ago who was really worried about a family member who was having really significant mental health issues, was very isolated. They were really worried. They didn't live in this area, but they knew that their family member did. Really worried. Spoke to Support Northants. They were able to work with that person, to go around and see them and spend time with them and say, actually, what would be really great for you would be if we helped you with your mental health services, but also, did you know there's a really fantastic like befriending type service in your local area? And on a Wednesday, they do this. That is the sort of thing that really changes people's lives, and the voluntary community sector are brilliant at it. And we've got to really recognise that. I think as a council, we're doing that more. We're realising we're not always the best people to provide some of this. Actually, we need to enable the right people to do it. And for me, that's a really classic example. The other thing that we've done as a council, which I think is really important, is I've worked with voluntary community sector organisations for many, many years. And what they will often say is it's really hard to get infrastructure support. So it's really hard to know, how do I write a brilliant bid to get some funding? How do I evaluate what I'm doing to make sure that I'm able to then sustain that funding going forward? And what we'd made a decision on about 18 months ago now as a council was to put some funding into a contract that's now live that's called Aspire. And that is a group of different voluntary community sector organisations fronted by Groundwork, which is a very strong VCSE organisation locally, but lots of organisations up there to help our VCSE partners develop. So, for example, you know, how can people do a great bid? How can people learn what a really good safeguarding policy looks like? All of that sort of stuff is we've invested in that to grow a really thriving and sustainable voluntary and community sector. So hopefully that answers that element of that.
Thank you. Can I also ask another one? What lessons have been learned from community-based pilots or health promotions in the past year, the year 2024 to 2025?
We've talked about some of the things we've done. So Pippa's example of the insights we're getting around some of that test and learn work in Corby, for example, around smoking. We're learning a lot about how our services should look, really. In terms of those sort of health, what used to be called health promotion or health improvement campaigns, they're things that we run routinely. We don't necessarily always evaluate the impact of those. We might evaluate how many hits we've had on certain things, for example, but we see that very much as the start of a conversation. So, for example, we've done some interesting work in the last year and a half. I think it was about the co-sleeping. So, for example, we know that it's really hard having a baby, isn't it? And it's really tempting to co-sleep with that child. And we know there's been cases where co-sleeping with children has very, very sadly led to the death of a baby. So we've done that sort of work. But what we always do with that is work with the best partners to help us do that effectively. So I believe it was the Lullaby Trust. And now my colleague Helene would be able to tell you chapter and verse on this, but she's not here this evening. But that's the sort of work we've been doing at that sort of level. I think in terms of test and learn. We'll have a lot of things coming up through the health and wellbeing strategy. So you'll know, or you may not know, that linked to that strategy is funding. So we're doing some innovative bits of work through there. One of the examples, for example, is we're investing in financial resilience locally. That's something from a public health perspective. You might think, why is public health interested in that? Because it's a fundamental thing. If you're not financially secure, actually your health is never going to be the front of your mind, because you've got to be financially secure to do that. So those sorts of projects are now underway, and we're starting the evaluation of those. So some of that will be coming out. But we evaluate everything we do, particularly where there's a cost. So if we've invested in an intervention, we will always make sure there's a contract and that's managed, for example. So we are doing that. I don't think, have we got any examples apart from the Corby one that comes to mind immediately? Oh, yes. That's a good one. So, for example, one of the areas we've put some money in and we're now learning from is dementia. So dementia affects huge amounts of people. We will all be touched by dementia in some way, whether it's ourselves or with some people we love or people we know. And so some of the work we've done, which is quite innovative, is we've looked at developing a centre for excellence of dementia care, and that's working with our fabulous partners at the Autumn Centre here in Corby. But what we want to do is then test and learn that and provide that kind of support for all of the areas of North Northamptonshire. That's how we want to work, because we want to be able to try something that's innovative, try something that's different, and then see if we can evaluate that and get better kind of impact by scaling that to a different sort of level. That work is ongoing at the moment. We've managed to get somebody doing a PhD on it, which is really exciting, because hopefully that will show us everything we need to know about how do you become a dementia centre of excellence. So that's the sort of work that we're doing. It's very much bread and butter to public health.
Thank you. Excellent.
Thank you, Councillor Lumsden. Any other members have any questions? Go ahead, Councillor Pengelly.
Yeah, it's picking up vulnerable and isolated people, and what we've seen in the change of lifestyle, and especially things since COVID as well. We have a lot of people, and you said earlier that I'm in touch with the community, and I see more constituents than probably any other councillor, and it's just one of them things. But what we see is there are people on our estates that we don't know who they are, if they're okay, if they're alone. We don't know, are they well, are they not well? And we have instances of people being found 3 weeks after they died, 4 weeks after they died. And a lot of that is people coming out of hospital, and they have the support for the first few days, and then they're on their own, and they're lost to society. I'm just wondering, what can we do? It's not only your problem, it's our problem as well, to try to tackle that. We all used to know who our neighbours were. We all knew we could, and the old thing that we all say, we kept our doors open and whatever. Now we don't know who the person is 2 doors away. And so we don't know what's happening in the house. We don't know what the issues are. We don't know if it's an old lady. Well, we know it's an old lady. We haven't seen her. We used to go in and talk to her. That doesn't happen anymore. I'm an old man now. And I'm just wondering, how do we tackle that? And how are you tackling that? And you'll be seeing it more and more, especially since COVID.
You're absolutely right. And people can be lost to statutory services quite easily sometimes. I'm very excited about the family hubs, actually, because that's a good model, I think, for if you've got a really good family hub that is offering lots of different opportunities, it's linked into lots of different services. And I was at a family hub recently, actually, and was really impressed by the breadth of people who were in there. So there was a group of people in there getting support for breastfeeding. There were people in there who were talking to different services. It just felt like you could have been anywhere. Do you know what I mean? You could be anywhere in a community. So I think there's something about making sure we've got lots of attractive offers for those. The other thing, and I think you're absolutely right, is old-fashioned community development, actually, is something. When you go to some of our community centres, and I'm thinking of Kingswood, for example, when you go there, there are people in there who know just about everybody, actually, in the local community. And it's how do we harness that to make sure that that local knowledge is feeding into the services that we've got. I'm a really big advocate for the more we can do around what I call old-fashioned community development, but people feeling part of their community, I think is absolutely essential. But we have to sometimes offer things to bring people out to do that. The other thing about people coming out of hospital, for example, we know that's a very vulnerable time. And certainly, I mean, there are some people who've got family or they've got neighbours who are able to go and do that support, but there's some people who haven't. And I think that's where our voluntary community sector organisations always seem to have great links with those communities. I think our role is to support that and also always be mindful that there are some people out there who do need that extra support.
Yeah, I just want to come back on that because it's also the issue with COVID and people being terrified. And I'm sorry if I offend anybody here, but things like the flags, well, a lot of people think they're really, really good and aren't they looking... For some people in the community, it means they're scared and they're not coming out of the house. I'm not saying that the flags would do anything, don't get me wrong, but it does worry some people in our community that they'll think, I'm not going to come out because of this. And we need people to come out and talk to us and tell us what the concerns are. And I know in some of the sheltered schemes, and I go in all the ones in my ward, and there's some now, you've taken a lot of them, Julie, now, but on them, where people used to come out and play bingo and join the common room or whatever, they stay in the house. There's that fear of, can I catch something? Is there something still out there? The COVID thing, that worry is there, and I just, it's horrible because I see it all the time, and I know you'll see a lot more than me.
No, it's people are really, and the other thing you are also that influences that is antisocial behaviour and fear of crime, and we know that communities, even if the level of crime actually is not as high as people think it is, it doesn't matter. It's the perception of and fear of crime that does actually keep some people in their homes. And certainly this is something that the council, I know, because antisocial behaviour and community safety sits with me. I'm the chair of the community safety partnership as well. I have many roles. That is something that we really want to tackle head on, because I think when you feel part of your community and you feel safe in your community, you're more likely to go out for a walk, you're more likely to go out on your bike, you're more likely to go and meet your neighbours down the road, you're more likely to do lots of different things. And antisocial behaviour, even at fairly low levels, can really affect people's sense of belonging in the community and also make people feel slightly more fearful of going out and doing things. So I think there's many different things that influence people. This goes back to our role as a partner. So the police, for example, in terms of crime and antisocial behaviour, we need to be working really closely with them to make sure that we've got the best offer possible around antisocial behaviour and crime. And we are doing that through the new community safety plan that's being written at the moment. Antisocial behaviour is going to be really strong in there. We're going to do something different, hopefully, in that space as well. We've got to get everything. We've got to think of lots of different facets of people's lives that influence whether they are going out and being part of their community. You've got to have an offer for people. You've got to have people feeling safe. You've got to have people feeling that, exactly your point, Councillor Pengelly, that not fearful of what's going to happen to them, whether that is that they catch something like COVID or, you know, we've got to really offer people assurance and support when they need it.
Thank you, Councillor Pengelly. We are 10 minutes away from the meeting guillotine, so I'm going to ask if anybody would like to propose extending the meeting. Is that a proposal, Councillor Pengelly? Seconder? Julie, can I get a show of hands on? Unanimous. Thank you. So we'll crack on. Councillor Brooke, did you have a question?
Yeah, sorry, just quickly. So you have a thing called the Agewell team in Northants, and maybe it might be a good idea that Councillor Pengelly should familiar himself with that, because that is designed exactly for what you've just said. It is to help people stay in their homes when they come out of hospital, to be looked after, to help put the services in to help them. So, and if you're not familiar with that, then maybe you should be, because you can wander around your own area and familiarise people with it. They can self-refer, or their doctor can refer them, or maybe even the hospitals when they're coming out.
Just want to come back. I'm aware of a lot of the outreach support and everything as part of my job. What I'm aware of it, what I'm trying to say is we're not aware of the ladies and the men that are in houses that haven't got any support. We're not aware of them. We don't know who they are. We can't touch them. We can't feel them. And so they can't do it. And how do we tackle that? And I think you answered the question that how you said was, we've got to get back to this community way again. Let's knock on that door 3 doors up. How are you doing, or whatever. Let's go around the shelter schemes. How are you, Mrs. Jones? Ain't seen you for a while. That's the way to do it. And I think and that's when we can start. And part of what I'm going to say later is about us all finding out more about signposting. How do you signpost? Who do you signpost to? Things like Handyman's Club for mental health. Things like the age concern. There's loads of the group, like you said. There's loads of bodies out there. But this is important for us as councillors to know that, to work with the health board in saying, look, we know how to get to. So I agree with you.
Yeah. I mean, I signpost a lot of people to it. But as I said, they come out of hospital, they go into their house, they sit there, they get a short amount of time from the hospital. But realistically, the hospital should be saying, there's nobody here to look after this person. Let's get someone in to help. I understand. I know most people that live in my road, in my little area, but it's, as you say, a lot of people don't. Anyway, that's it. Thank you.
Thank you, Councillor Brooke. Any further questions from the members on what was the topic? Community engagement and voluntary sector collaboration. No? Okay, we'll move on to the last theme then, which is outcomes evaluation and future priorities. I'll kick this one off. First question, how is progress against last year's DPH report being tracked, and are outcomes being measured transparently?
Yes, we're all about outcomes because we have to be able to demonstrate the use of the grant and that we're using it to good effect. So we have a suite of outcome measures. Some of them are reported at executive, for example. So when we do our executive, the KPIs for the organisation, quite a lot of public health measures are in there. We can benchmark because they're national ones, which is great. So we have a mixed approach to that. We have things around, so there's a particular metric around smoking that we use, for example. There's one around childhood obesity is nationally measured. There's lots of things that we do in that space, but we also evaluate everything we do as well. And to give you an example of that, going back to Support Northants, for example, we have a member of our team who has a epidemiology PhD, and they've done a really good evaluation of that, looking at outcome measures that are everything from what is the impact in terms of investment, but also what is the impact on the individual, how do they feel, which I think we mustn't forget how important that is. We want to know that this is making an impact to individuals, and then also what is the impact on services as well. So that's how we approach that. We also, it's really important to note that we have a lot of contracts in public health, so we have amazing partners that we contract to. So to give an example, NHFT, so Northamptonshire Healthcare Foundation Trust, we work very closely with them around young people's services. And we manage that contract really effectively with them in partnership. So there's things within that contract that we need to make sure that they're meeting, and that links to the outcomes that we want to see. So, for example, we want to make sure those services are seeing mums when they have their babies. That's really important. So that's one of the things that we measure, and that those sorts of metrics are shared with all members. The other thing that we'd really like to get really good at is making sure we've got a really strong model for return on investment as well. It's quite a difficult thing to get that right, return on investment. And again, thinking about the work with Support Northants, we're working with colleagues in other areas of the country to say, how do we do that most effectively? And sometimes what makes that really hard is it's hard to know who benefits. So if you think about Support Northants, who are doing amazing work around a person, actually what they're doing probably affects the police, probably affects emergency departments, general practice, it probably affects adult social care. What we have been able to show through that evaluation is reducing the level of need for adult social care. That's great to be able to evidence that. So as well as those big metrics that we collect, which are national ones, which we benchmark, we also then do that evaluation as well. In terms of progress from the last Director of Public Health report, so you'll see that we've had more people coming through our smoking services, we've had more people setting quit dates, we've got a really good, what we call a conversion rate for how many people come in and how many people then quit. So we are seeing progress in all of that. As we've said throughout tonight, we want to do more. We want to make sure we're getting to those communities where smoking, giving up smoking is not where we want it to be, but certainly we do track all of that, and most of our data is nationally collected and done in a way that's uniform across the country.
Thank you. The next question was, are there specific public health challenges that should be prioritised in future annual reports or scrutiny sessions, such as air quality, addiction and child health?
So from a direct public health report perspective, we're very early on in our life as a council in terms of public health. We came over from the NHS about 2014, but obviously this council has only been going for 4 or 5 years at the moment. So this is only our third DPH report. The reason why at the moment what I'm focusing on is what we've said we're going to do in the health and wellbeing strategy, because it's really important. If we say we're going to do it, we want to show progress in that. We show that through the Health and Wellbeing Board, but it's also important to show it here. In the longer term, we can pick a particular topic to look at. So some interesting DPH reports that I've read, because clearly it's a bit of an evening thing. You know, want to go to bed early and read a DPH report. And some, for example, I read a fantastic one recently on stigma. So you can do something that's a very specific subject, and you might be interested in the role of stigma in how people access services. So we will go to that in the longer term, but next year we're going to focus on those areas of the health and wellbeing report strategy that we've not focused on in this report. So that's where we're going to go. In terms of scrutiny and what might want to come forward, I think we've had a really brilliant session at Scrutiny around addiction before, particularly our drug and alcohol services, and I'm not sure if any members on this committee were there, where we had service users come in and talk about their experiences, and that was really powerful. That's something we can do, and certainly we are recommissioning that service at the moment, and Scrutiny may want us to come in with what that's going to look like. So that could be an area that we want to do. I actually would really welcome something on our joint working with our health partners, would be really, really good, particularly around prevention. We had some discussion earlier about the fact the NHS is under extreme pressure, and sometimes funding for things like prevention can fall down a little bit, so that could be something that we might want to bring to scrutiny. In terms of public health topics that we haven't had at scrutiny yet, we'd really like to bring healthy ageing. We're doing some work on that, and we'd really like to bring rural health needs as well. In fact, we have a great big list, Councillor Gibbs, of what we'd like to bring, but we are open to any suggestions. We will come and answer questions and present on anything that you find interesting or useful or important.
Thank you, Jane. Just to clarify, given the vote to extend the meeting guillotine, that's now for 9:30. Okay. I've got one more question, then I'll open up the floor for members to ask questions about future reporting. What can the committee do to support long-term public health planning and system accountability?
Excuse me, I've spoken a lot today. I've been talking at one council event. I think the committee, the role of scrutinising across the system is really important. So scrutinising what our partners in health are doing is really important. Scrutinising how effective our partnerships are, I think, is something that we really, really would like to strengthen and take forward. I think the role of this committee health scrutiny is essential, I think, because it's about holding us to account for how we're spending this money to get the best impact for our population. So I think cross-working would be really helpful, particularly with the NHS. My role as an independent DPH means I work a lot with the NHS. I kind of work across both sectors, so that would be really helpful. The thing that I would really like all members to do is to be advocates for public health, and I know you are. We've got some great stories this evening of how people have made life-changing decisions themselves to stop smoking, for example, or you are working with our communities all of the time. So advocating for the services that we provide, advocating for how people can access services, how people can be part of their communities, Councillor Pengelly, like you mentioned earlier, that would be fantastic. And we're really happy to put on sessions for all councillors around things like, how do you have some of those conversations with people? How do you talk to somebody about the health and well-being in a way that actually is useful and doesn't feel like you're preaching, because that is something we hear sometimes. The other work that we do a lot on, and this is something that I'm sure councillors will, if you haven't had experience of this, you will do, is about mental health. So mental health, and I'm sure for Councillor Pengelly, for example, will have had experiences where you become very aware of mental health issues. So we could talk to all councillors about what's available there from a service perspective, but we also do some great training on suicide prevention. And I've spoken to a number of councillors in my time here who have had actively suicidal people speak to them. And so that's the sort of thing we could also offer members in terms of helping you in that advocacy role as well.
Thank you, Jane. Got plenty of notes there for me to take away. Any further questions from the members? Go ahead, Mark. Sorry, yeah. Councillor.
One of the most crucial part of our health service, from adult social care and care homes to people go around people's houses to Kettering General Hospital to Corby Diagnostic Centre, is the staff. And the health service is full of staff from all over the world, all over Europe, all over this country. And how do you think that we can show them that we value them, and we think that the people coming to this country to help and work in a health service are really, really important to us, and we thank them for that. So I think that's something we've got to look at going forward. Also, and I'm sorry to raise this again, there is a massive concern in Corby, and I don't know, and I've got to emphasise this because I've had loads of calls, and no other councillors have, about children cancer in the town. I don't know if that figure is higher than the national average or lower than the national average, but there's a lot of worry and concern out there. How do we tackle this? What we get, and I know it's a difficult question for us, but how do we tackle it? And there's also this issue, and I don't know if it's an issue or if it's not an issue, but my casebook and Facebook is full of people saying that the soil was dumped in all different parts of Corby, and certain house estates are poisonous or whatever. And you can imagine living on a new estate where you bought a house, you'd be terrified. You'd be going, oh, wait a minute, I've spent £300,000 on this new house, and I'm being told there's poison coming up through it. I don't know if it's true or not, but how can we help people dispel this, or say, look, there is an issue here? And for everybody in this room, this isn't you haven't made this happen. This is something that's happened in the past, and it's something you have to tackle and work with. And I know how difficult it is, and I feel for you. But as I said at the full council meeting, I remember 20-odd years ago being told there's people going around saying that there's going to be a big birth defect thing in Corby. Don't worry, it's going nowhere. And we ended up paying out millions of pounds. So I think we've got to look, and now we can. People are worried. There's mums that are worried. How do we stop that worry, and how do we support the people I represent, and you will represent as well? Thank you.
Very pertinent question. So I have been approached by a family and a group in Corby, and we are doing analysis of that data at the moment. And I totally see that we need to be able to objectively look at the data. Now, we don't hold some of this data, but it doesn't mean we can't find it. Yeah. So what we've agreed to do is, and it's underway, it's almost complete now actually, and I've been back in contact with the contact I have for the families about that to start those discussions as soon as we've verified the data, is we look at the data. Yeah. So one of the problems we've got is that some data won't go back far enough, but we can look back for a number of years on data. And the best way of doing that is saying, okay, let's try and find the data we've got for cases of childhood cancer, all childhood cancers, and then we map that. And we say, what is the rate of that across the whole of North Northamptonshire? Then what does it look like in different areas? And that is underway at the moment. So that's really important. And we do that completely objectively. because that is it's got to be a transparent, objective process. One of the things that we want to do is get all of that data checked by a statistician as well, because we want to be able to feel confident about that. It's not our data as well, so we're using other people's data. But absolutely, my job as a Director of Public Health is to advocate for the population, and if we have an ability to support the population with answering that question, absolutely we'll do it, and we are doing it. So the timescales for that will depend on data verification. It's incredibly important it's right. It's so important. It's one of those things in my career. It's got to be right. It's very, very important. But we are doing that at the moment, and then we will share that at that point. And it may be. I mean, I haven't had the data presented to me yet. I don't know. It may be that there are no areas that have higher rates than others. There may be that we don't know. And we're doing that objective analysis at the moment. The other thing that we can do is we've spoken to so many people about what other data is available. So we're also going down every avenue we can to say, for example, the National Cancer Registry, what do you hold? What can we get from you as well? So we are doing that, Councillor Pengelly. And you know, I'm a parent, lots of us are, and you know, we would all want somebody to take that up and to respond to that question. So we are responding to that question.
That's encouraging, because what's being fed back is before the wrong data came out, apparently, well, 20-odd years ago, and people got told there wasn't that birth defects in Colby were no different to anywhere else, and that was wrong data. So I think you're right, we've got to get the correct data, and we have to work with the families to say, look, this is what the facts are, and if they are higher, then we have to tackle that. Yeah, thank you.
Thank you, Councillor Pengelly. What I think we'll do now is move on to our holding recommendations, and then I'll open the floor after that for any further member recommendations. So I'll read these out and then we'll go through them one by one to vote. So the first one is the committee receives an update in 6 months' time on key health inequalities across North Northamptonshire, disaggregated by locality and population group, alongside actions being taken by local area partnerships to address these gaps. Do I have a proposer for this one? Councillor McLean, seconder. Councillor House. Could I get a vote on this one? It's unanimous. Thank you. The second one. Public Health continues to expand its engagement with the voluntary and community sector to deliver targeted preventative programs and report back on reach, uptake and outcomes. Do we have a proposer? Councillor Davies, seconder. Councillor Brooke. And we'll go to a vote on that. 1, 2, 3, 4, 5. That one passes. And then finally, the next annual report includes a formal review of progress against the current year's themes and recommendations, with clear outcome measures disaggregated by locality and population group, and public accountability for change. Do I have a proposer? Councillor Davies and a seconder. Councillor Harrison. Let's put that to a vote. Show of hands. Okay, all unanimous. Thank you. Did all of that make sense? Yeah. Any members' recommendations?
Got a proposal.
Go ahead.
Coming back to your commentary about a 50-50% chance of living or not with smoking, and also about some of the factors that can impact upon your life expectancy, I think what would be useful is a simple diagram or animation encapsulating that. So I propose that some simple, easy to read and understand presentation that we can share would be really useful.
Councillor Geary, I'll take you as the proposer for that.
Yeah, I propose that.
Seconder.
Thank you.
Councillor McLean, and show of hands. Thank you very much. Any further proposed recommendations from members? Okay, make it very brief.
It would be really quick. When I worked at Luton Borough Council, the lady looked after social public housing, health and safety. She was a smoker, and her argument would always be, if you've got a married couple and dad becomes a bit heavy drinking, gets a bit handsy, and mum takes the kids and everything, the council have to house them. Dad loses his job, for argument's sake, then the house is gone, then Dad has to be housed as well. Do we have numbers for those sort of occasions when that might happen?
That wouldn't sit with me. That sort of data would probably sit with
That's
housing.
alcohol, is it not? I'm just thinking like the drink side of it. That's more costly to Mr. and Mrs. Taxpayer than potentially smoking.
But that's a complex example you've just given. So that is not just about alcohol. That's to do with a whole range of different subjects.
But it's the knock-on effect, isn't it?
It is. Alcohol has so many different impacts. So we know it's strongly associated with domestic violence. It's strongly associated with lots of different things. But I wouldn't have data on that sort of level of specific detail. Housing, for example, might have something on that, but I'm not sure. Our alcohol services probably wouldn't have that either. Okay.
Thank you. That brings us to a close on Agenda 4. Jane, Pippa, thank you so much. I think Councillor Harrison said earlier we should clip a certain part of that. I think we should just clip the whole thing and deliver it somewhere as a podcast. That was a pleasure to listen to. Thank you so much for your time this evening. On to item number 4. Could members please note the contents of the scrutiny work plan for the forthcoming meetings? Our next one is on the 18th of November. We have 3 items. We have the KGH annual report, we have the NHFT annual report, and we have the winter preparedness plan. Any questions? No? Well, it is 9:15 p.m. It is my wife's birthday. I would like to see her while there's still a few hours left in the day, so I will bring this meeting to a close. Thank you.